You have a nurse that is aware of several clients. Which client situation is concerning? Is it prioritization question? Or you get a bit sharp in selecting your answers. That means, do I expect this information? If I expect it, then I'm not going to worry about it. They're all going to look bad. And as you can see, there's a situation. They give you a medication each. They give you the condition. Divide it into two. And then figure out who is not the problem, like Nemitrogen for bipolar patient, Losartan for CHF, Aburonef for somebody who has hypokalemia, acetaminophen caffeine for migraine. Ask yourself, is there a relationship between this? If there is, are you going to be sharp about it, or are you just going to be what? Let it be expected finding, and then you move on. You don't even worry about it, no matter how bad it is. Don't use the diagnosis and say, hey, it's a CHF, so I have to pick it. No. Look at the situation and see if there's something that you should worry about. If it is, then I want you to just think about it carefully. I see lamitogene is an anti-epileptic. I see bipolar. Anti-epileptic can be used as a mood stabilizer. Therefore, this is fine. I move on. Losartan is an ARB. It can be used for CHF. It helps with remodeling and then slow down the heart in terms of the not through the beta blocker way, but in a different way. So it's very good when you have a heart failure. You can give losartan, which is an ARB or ACE inhibitor. Whatever ACE inhibitor does, a losartan can do it, right? Which is ARB. Albuterol nebulizer and hypokalemia. Albuterol is one of the things that can put potassium inside the cell. So it's a beta agonist. It's going to push the potassium inside the cell. It's going to cause what? Hypokalemia. Patient is already hypokalemia. There should be something buzzing in your ear saying, no, I have to be sharp about it. They don't have any questions to ask you. This is the way they're going to create it, right? Albuterol, hypokalemia. If you know your content, you say, hey, this is the side effect of albuterol. It's hypokalemia. Patient is already hypokalemia. My antenna should be ringing. This is a bit sharp, electrolyte problem. Acetaminophen caffeine, right? For somebody who has migraine. Yeah, this is one of the regimen for acute migraine. Therefore, I should not worry about it. And D is fine. And so your right answer is C, right? And next is reviewing a client EKG strip. Which documentation is appropriate? So you got to click on the EKG and see what documentation is appropriate, right? Which documentation, which of this is appropriate? So this is what you have. What do you see? Does it look familiar to you? Does it look like a normal EKG strip? Do you see a normal P wave and then a QRS? P wave, QRS. Is there anything abnormal that you're looking at here and say, what is this? I've never seen this before. Look at this. This is your P wave. This is your QRS. Look at your P wave. Look at your QRS. Do you see anything? P wave, QRS. P wave, QRS. What do you see that is not supposed to be there? If you look carefully, you see these spikes, they're not supposed to be there. These spikes, there's spikes before every wave. There's a spike before P, there's a spike before QRS. Spike before P, spike before QRS. You see these lines? Usually you don't see it in EKG. You see these lines coming down. No EKG had these lines. What are those lines? They have the name. This is what we call, it's a pacer. It's a pacemaker spikes. So these are spikes from pacemaker. And if you have two of them before P and before QRS, it's a dual chamber. So this is a dual chamber EKG, basically. The other way too, if you don't know, it does not look like sinus tachycardia. Sinus tachycardia means it's faster, right? It doesn't not look like atrial fibrillation. I can see the P wave. I don't see atrium is fibrillated, and I don't see ST elevation. So this is a dry cardiac chamber. Let me show you it again. You can see it. See, you see these spikes, these lines coming down. Usually you don't see it in EKG, these spikes. So those are pacer wire that you're supposed to know. So it's not ST, it's not atrial, it's sinus tachy, it's ST. So those are pacer spikes. Next question. A nurse provide care for a client 38 weeks gestation in labor receiving Oxytocin infusion. The nurse notes the fetal strip below. Based on the strip, the caring nurse will do what? So break down the question. We have 38 weeks baby, is in labor, is receiving Pitocin, and we saw this strip. What are you going to do? Based on this strip, the caring nurse will do what? And then you look at the strip. You don't have to worry about it, just go through with the flow. And this is what you saw. This is what you saw. Fetal EKG. But the first thing is to look at the base and see what the mother is doing. The key is 5 contraction in 10 minutes. So 5 or less. I see this is 1 contraction. 1, 2, 3, 4, 5. This is good. The second thing you look is the duration of contraction. How long from one place to another, 1 contraction to another. It should be less than 90 seconds. And this 1 bar to 1 bar is 90 seconds. No, 60 seconds. So this is less than, so this is good. Then the time after 1 contraction to another, at least close to 2 minutes. This is a little bit shorter, but it's almost close to 2 minutes. That's all. Then you look at the fetal heart rate, it's almost like 140. So what do you think? 5 contraction, the heart rate is always in the 140 range. We have what? No evidence of tachysystole. We are within normal. So this is a normal fetal EKG. So what is the nurse going to do? Place the client knee to the chest, notify MD immediately, continue to monitor liver, or stop the Pitocin. I've given you the answer. This is a normal fetal heart rate. Therefore, we should just continue to monitor liver. Nurse performing medication reconciliation on the client with serum potassium of what, 3.1. Which prescription the nurse should hold? This is another question that you got to think about. A, I'm doing, look at the way that I said the question. Medication reconciliation, and I see potassium of 3.1. Which medication you should hold? When you see a question like that, rewrite it to your own. What is another way of writing this question? Tell me, what is another way you can just change the question the way you want? I'm taking, there's one medication here that is causing hypokalemia, or a medication causing 3.1 hypokalemia. So that is all. What medication will be doing this? So which of these medication can cause hypokalemia? That is what the question is asking you. The first one you may not know, but look at the last name, Pearl. He has the Pearl as the last name. That means it's an ACE inhibitor. If it's an ACE inhibitor, you have ACI, right? Angioedema, cough, electrolyte abnormality, and teratogen. Electrolyte abnormality, it increases potassium. This guy is going to increase your potassium. It's good. Eperinol, what is that? This is potassium sparing. I did not give you spironolactone. I intentionally gave it to you. So this is potassium sparing. I know it's not causing that. Amilrolide is another potassium sparing. Then you left with this test taking strategy. If I know this are all potassium sparing, well, I got to pick this. How this steroid causes hypokalemia? It increases aldosterone. As a result, You have increasing your sodium. That's why you have hypertension. Potassium is low. Therefore, we got to worry about steroid as the cause of this electrolyte abnormality. Today, a bunch of maternity strips so that you can get comfortable. And let's provide care for a client at 38 weeks who is in labor, right? And receiving Pitocin. Same question. The nurse notes the following fetal strip on the monitor. Which of the following actions should the nurse take? Now you have to click on it. What do you see? I've told you, show you how to read fetal. Look at the bottom and see I'm in a contraction. Then look at what the baby is doing. If there's more than 5 contractions, it's tachysystole. Do you see five contraction? See the duration from one to another. It shouldn't be longer than 90 seconds. And then from one end to another, make sure it's long, at least 2 minutes, right? If everything look fine, look at what the baby is doing. His heart rate is like 140 something there. And look at what happened after each contraction. Then you can figure it out. You can take your paper, you can take your ruler and draw lines. This is the concentration, contraction, beginning of contraction. Look at the baby, it's fine. As we contract, when we get to the top, baby is okay, right? When we finish, we're about to calm down, that's when the baby calm down. So baby does not like it when we reach the point and then we finish contraction, then it calm down. It does the same thing. I draw a pic and I see when I'm at the maximum, that's when the baby heart rate start come down and they come up as I finished. Same thing, when I'm at the maximum, baby heart rate coming. So when you are at the maximum, that's when the baby start getting mad. What does that mean? What? Late. We are late to our deceleration. We are being late to our deceleration. Therefore, if you're late, what do you do? Now application. Application question is this. Being late is not enough. And the best way to answer this question is you use this, okay? I know everybody know, so you got to figure out what is that. To be late is to have the P, right? Which is placenta insufficiency. Down, you write it, placenta insufficiency. You see, I'm showing you how to answer questions like using critical thinking. Placenta insufficiency. What does the word means insufficient? Insufficient means it does not have what it need. What does the placenta doesn't have? Well, it doesn't have the oxygen and it does not have the blood it needs to give it to the baby. That's what it means, placenta insufficiency. So provide maneuvers that will give the baby all the placenta information that they need. So what do? So you know late deceleration is what? Placenta insufficiency. So fix it. If you have placenta insufficiency, what is the best position to provide blood flow to the mother? Don't tell me knee to chest position. It does not provide blood flow. You got to take the uterus out of the pelvis and out of the IVC, inferior vena cava, the vein and the blood supply. Therefore, don't pick knee to chest position. So no knee chest position is mostly lateral position. You put the baby in the lateral position and that will help blood flow. You can also improve blood flow, right? By giving them what? What do you going to give the baby, right? The baby is getting Pitocin, so we got to stop it. So stop the Pitocin. After you stop the Pitocin, you can give them blood flow. What is that? IV fluid. This will help blood flow and it will slow down contraction, right? We all know we got to give them oxygen, and this is where the content matters, right? You never give OB patient nasal cannula. Never pick an answer in your board. It's always going to be wrong. OB patient need a ton of oxygen. Nasal cannula is not enough. He's just giving them 6 liters. You want to give them something better, either a face mask or non-rebreather. So that's why, even though this is an oxygen, it's a wrong answer because of nasal cannula. Don't just see the oxygen and then start to pick it. So I don't want you to do that. I want you to get all the points. So focus on the rest of the question. And I explained to you, knee to chest position is for compression. So called compression, not placenta insufficiency. Now, I want you to try this one. And let's provide care for a client prescribed what? Guaifenesin. Client asks the nurse the purpose of the prescription. What is the nurse best response? Like that, you got to be careful. You have to break it down and say, hey, I'm prescribing this medication, guaifenesin. He's asking me what is the purpose. What would you respond? You just explain the technical terms for that medication, what is used for. These are medication a bunch of people make mistakes about. I mean, we see them over the counter when we pop it like a candy, but we don't know the meaning of them. There's so many of them. You have Sudafed, you have mucolytic, you have all of them. Which one is guaifenesin and what does it do? Does it decrease inflammation? Does it stimulate mucus production? Does it suppress his cough? Or does it loosen up the mucus? Mucolytic is anything that if you have mucus here, this is mucus, they're going to break it into pieces. And then it will be easy to pass. Mucolytic do the same thing like expectorants, like help to get rid of it by making the mucus very thin, losing it up, right? Decongestant basically it help you like release the mucus itself in your nose. If you congest it, it will decongest it for you. Antitussive basically it prevents you from coughing. It suppresses your cough. So when you get sick, figure out what condition you're having and which one you should choose. It does not affect your inflammation. It does not secrete mucus. It's not antitussive. It's losing the mucus. And so it can be considered as a mucolytic or expectorant and help you get rid of it. This is the same thing like acetylcysteine, and that you use for cystic fibrosis. So this one is the right answer. And it's providing care for a client at 37 weeks of gestation in labor. The next note, frequent variable deceleration on the monitor. What is the next first action? What do you want to do? What are you going to do? What are the first thing you would do when you see that? The first thing you can do is break down the question. It's a 37 weeks pregnant. The client is in labor. And what do you see? Frequent variable deceleration on the monitor. What does that mean? Variable deceleration. Before you can answer the question, I don't want you to go and pick an answer right now. Figure it out. What is variable deceleration? Okay? And then you say, oh, variable deceleration, I'm going to have cord is due to what? Cord compression or cord prolapse. If that is the case, ask yourself, what is going to cause the cord prolapse? And then try to fix it. That is the way you answer questions. And when you do that, you don't guess. Trust me. I mean, you go take the test, you say, oh, I know they're trapping me with this, and that. I know this, I have cord compression. What is going to cause cord compression? And if I know what is causing it, then I'm fixing it. I'm not going to pick an answer that is not going to take care of what? The cord compression. Then you ask yourself, what are the causes of cord compression? Well, the most common one is when the water breaks, right? You lose amniotic fluid. That is the most common one. When amniotic fluid lost, there's no cushion from the baby to the placenta. Then you push on the placenta. Or you can have cord prolapse. Those are the two things. So how do you fix this? They don't need C-section, right? They don't need IV fluid because the IV fluid will take a long time to get to the mother. You don't need to place the patient on supine position because that's the worst position you want. A pregnant lady should not be in a supine position, right? So therefore, we got to infuse the amniotic fluid back into the fluid that we lost. So this is the right answer. Amniotic infusion of normal saline. So this is one of the common conditions you see. Cord prolapse, cord compression is due to loss of fluid, and therefore the kid is going to show some variable deceleration. And the best way to do, you see, you can do this answer, you're going backward to the pathophysiology. I have variable deceleration, and let me show you what I've done right now. I break down the question. I know it's variable deceleration. I wrote down my VCHAP and I said it's a cord compression. And I go to the content. What is going to cause cord compression? Loss of amniotic fluid. If I know loss of amniotic fluid, then I give you back to you. Therefore, amnio infusion is the right answer. Break it. We have a 38 weeks pregnant lady who is what? Having what? These strips. She's in labor, and we saw this. And therefore, what action are we going to take? Just open it up and then see. If you don't master how to read it, like I said, I have some free videos that you can watch and learn how to read it. But this is what you have. What is the diagnosis? Make the diagnosis before you look at the answer. So this is what happened. We have 3 contractions. It's good, right? The distance from one contraction to another, almost 2 minutes, is good. But what happened? Baby contract, and then boom, mommy come down. Baby and mommy at the peak. Mommy go down, baby go up. It's happy. Mommy start to contract, baby start crying. At the peak, mommy said, I'm coming down. Baby said, I'm happy. Mommy contracted to the top. Baby said, don't do that again. Mommy went down and baby said, thank you very much. So what do you see? Whenever mommy starts to contract, baby is crying. Therefore, this is early deceleration. Based on your VCHOP, early deceleration is just to monitor progression, make sure everything is going out the way it's supposed to. There's nothing to do. You don't need C-section, you don't need to chest position, you don't need left lateral position, you just have to monitor progression. I just want you guys to master EKG and how to interpret it. When you're taking your board and you see it, don't worry. Don't like, oh, I'm going to get this question wrong. If you figure out what is the rhythm, there's no way you're going to miss the answer. Once again, if you read the rhythm, then the rest of the answer choice is free. You already know it. You'll be fine. I changed it. Now I changed the mood. I went to my favorite topic, mental health. If you need some help, just check Adapt NCLEX. If you're hearing my voice for the first time, this is Adapt NCLEX. A nurse provide care for a client with what? Diagnosis of schizophrenia. Which finding is consistent with positive, negative symptoms? You have to know this. It's a common question they ask all the time. And schizophrenia, the diagnosis is based on positive and negative symptoms. What are positive symptoms and what are negative symptoms? Is this consistent with the positive symptoms or this is positive symptoms? So you keep on checking and see which one it is. The content here. What is the content here? What are positive symptoms? Is what is used to diagnose schizophrenia, what everybody knows. Negative symptoms, they are depressive symptoms. That is all the concept you need to answer this question. That's all. Lack of energy. When you don't have energy, that sound like you depressed. So I'll pick that one day. Right? And apathy, right? sound like a negative to me. It sounds like negative connotation. And if you're not taking care of yourself, the disheveled appearance is all negative. Which of the following we use to make diagnose schizophrenia? Delusion. People who have delusion, so it's a positive symptoms. People who have hallucination, we think they are delusional. They have schizophrenia, right? And people who have disorganized thought. So those are signs of schizophrenia. Delusion, hallucination, and disorganized thought. They are all things you can use to make the diagnosis. So disheveled appearance is a negative symptoms because it sounds like depressive. Disorganized thoughts is positive. But this is another key: psychotherapy and pharmacology. Psychotherapy, you cannot, this is the reason why when somebody is hallucinating, you can't just talk to them out of it. If somebody is delusional, you cannot talk to them out of it. Science makes sense. There's no memorization on it. When you have a delusional patient, you can't just try to convince them. They have a fixed mind of thought. How can you convince that person? There's no way. He thinks the heck is coming to an end. Do you think you can change that? We see it in our society right now. There's people out there that have like fixed thought about something, about whatever happened a couple of years ago, and they never change. That is a delusional thought. What are you going to do? You can't talk them out of it. The only thing that you can do is to give them medication. So positive symptoms respond to what? Pharmacology. Pharmacology. And negative symptoms, yeah, you can talk them when they have apathy, they have delusion, they have disheveled appearance, they have flat affect. You can talk to them, hey, don't do that, all those things, and they will change. They go wash themselves. So psychotherapy is good for negative symptoms, but pharmacology is good for positive symptoms when you have somebody who have schizophrenia. Okay, guys, so I hope you never go wrong when you see these questions anymore. You have to understand why we call them positive and negative symptoms. And this is providing care for a client in labor with the fetal heart monitor tracing below, which finding is consistent with the tracing. Click on it, and what do you see? Who can tell me what they see? Does it look like the first rhythm we saw? Does it look like the first one we saw? What is the baby doing? And what is mommy doing? Of rhythm strip is to look at first what the mommy is doing, how many contraction in 10 minutes. And then you can figure it out. So how many contraction in 10 minutes? And I told you, you should only have 5 contraction. I said 5 contraction in 10 minutes. How many contraction do you see? 1, 2, 3, 4, 5, 6, 7, 8. This is bad, right? 5 contraction, 8 contraction in 10 minutes. Therefore, you know this is bad. I call it bad. Mommy is contracting too much. Mommy is contracting too much. What is the baby doing? He just don't, he doesn't like it. It's just going too fast. Baby heart rate is going too fast. But you don't see any deceleration. You don't see baby going up, down. You're just going, it's like going fast around, it's more around the baseline. He does not like it. He does not feel good. And therefore, this is what we call tachysystole, urinary tachycardia. This is what we call tachysystole. So it's going too fast. Then the content here is what? If something is going too fast, when the uterus is contracting, if you don't know this, I'm telling you, when the uterus contract, at the peak of contraction, blood flow to the placenta is minimal. So there is no placenta blood flow. So the faster the mommy contract, the less blood flow going to the baby. So you have placenta insufficiency when you have excessive contraction. Okay, so we have uterine tachysystole. It's going too fast. It's going too fast. Based on that content, look at the answer. I try to trap you. It slows down contraction. I did not want to give you medication. I use the word so that you guys can know. Don't be surprised if you see it in your test. Tachycardia is slow contraction down. The patient is having tachysystole. Do you want to stop it? We use it for preterm labor to prevent contraction. We can use it, terbutaline is example. So somebody is in tachysystole, hey, you need to give them tachycardia to continue. I just trap you. The idea is to trap you. You stop tachycardia immediately. No, you can't stop tachycardia. You should let it go. So this one is the wrong move. Urine contraction are less than 2 minutes. Is that right? Uterine contraction is less than 2 minutes. Is that right? Yes, that is the definition of tachysystole. You have to have contraction and to be greater than at least 2 minutes apart. If it's less than 2 minutes apart, it will lead to more than 5 contractions in 10 minutes. So this is consistent with the problem. IV infusion. Whenever the uterus is contracting too fast, you can slow it down with fluid. So IV infusion. How about magnesium? We think we got to give this patient IV magnesium. Patient is contracting too much. Magnesium, remember, you can use it in asthma patient. It relaxes things. It slows down. It can be used preterm labor. Hey, if you're contracting too much, we can give you magnesium. There's a risk of hypoxia. I explained it to you. At the peak of contraction, there's no blood flow, no oxygen. So there's a risk of hypoxia. There's a risk for placenta abruption. Yeah, if the uterine is contracting too fast, you can get placenta abruption. So that's one of the things we don't want it to happen. So the more than 5 contractions in 10 minutes, we saw it, right? We counted. There were 8 contractions in 10 minutes. 1, 2, 3, 4, 5, 6, 7, 8. So this is also consistent. Place client in knee to chest position. So the last one, who want to do that? Place the client in knee to chest position. Tachysystole leads to what? Placenta insufficiency. In placenta insufficiency, we don't do knee to chest position. We do lateral position. So this is wrong. So our answers are this. Those are this is our extended selected apply. Okay, so just one question for you. And I try to explain it quickly for you. I think we have 2 more questions to be done. And let's provide care for nulliparous client at 37 weeks of gestation whose memory, I should say, whose memory spontaneously ruptured. What is the first action the nurse should take? I've already given you the answer. Memory rupture, what should you worry about? These are the buzzwords I call about test taking strategy. You go to answer this question, 37 weeks with memory rupture. What should I worry when the patient is in labor and a memory rupture? What is the first thing I should worry about? What I should be concerned with them? I've already explained it, but I said the question again to emphasize that. So what would you want to do? Do you check the color of the amniotic fluid? Is that important more than calling the doctor or preparing for delivery or checking what the baby is going to do? Trust me, the baby is not going to be happy. When the amniotic fluid comes out, the placenta get compressed, baby heart rate is going to go down. And therefore, you know what to do, right? Let's check what the baby is doing. Check this. That's the number 1. I'm not saying you shouldn't look for the color because they may have amniotic infusion. They may have like a meconium aspiration. Yeah, you got to check it. I mean, may have to call the doctor if you see something. They may have to need a C-section. But the first thing you do, prioritization. A, check the fetal heart rate. Is he responding to the rupture of the memory? If he's happy, he's having acceleration, you high five each other and you continue labor progression. So that's why it's very important. And the last question, I think. And then provide care for a client at 37 weeks of gestation who is in labor. The nurse noted a sustained rise in fetal heart rate from 145 to 180. What should the nurse suspect? You watching labor, patient heart rate jump. That's the fetus from what? Heart rate of 145 to 180. What is causing that? Test taking strategy. Even if you don't know, look at the answer choices. Heart rate, you can move from 145 to that. Ask yourself, will this increase my heart rate of the baby? Will spontaneous rupture increase the heart rate of the baby? Will placenta insufficiency increase the heart rate? And will maternal fever do that? Test taking strategy, adapting class. I hope you gain something from this. And good luck in your exams. If you need help, you should check my website, my YouTube. You can subscribe, you can share the video. If I give you opiate and you give it to the baby, it's going to have what? Bradycardia. If your memory rupture, we just saw it. We have cord compression. Baby heart rate is going to decelerate, right? When you have placenta insufficiency, there's also deceleration. It's a different kind of deceleration, right? It's hard. Maternal fever is the right answer. All these will lead to deceleration. They're going to cause bradycardia. They're not going to cause tachycardia. Apply your content. Look at the question. Come out with the buzzword. The buzzword for the question was heart rate going to 180. I have tachycardia. And then you said, which of those will cause tachycardia? None of this causes tachycardia. They all lead to deceleration. A, B, C will cause deceleration. Therefore, even if you don't know, they never lead to acceleration. So good luck in your exams.